Hi, everyone. Welcome to Breaking the Silence, a podcast produced by Angels Protection, Inc., where we uplift the voices of young mothers and women and the leaders, clinicians, advocates, and systems builders working to transform the healthcare systems that shape their lives. I'm your host, Makaila Davis, founder and chairwoman of Angels Protection, Inc., and Her Voice in Healthcare is a series dedicated to women whose leadership is grounded not only in expertise, but empathy. Women who understand that healthcare decisions, system design, and policy must center the voices of those most often unheard. This series honors women who lead with integrity, accountability, and an unwavering commitment to equity. And today's guest is a physician leader whose work sits at the intersection of vision, strategy, and care delivery, and whose leadership reflects what it means to design healthcare systems that truly serve people. Dr. Anna Flattau is a nationally respected physician executive whose career has focused on building sustainable, mission-driven primary care systems within complex health environments. She currently serves as the Enterprise Chief of Primary Care at Jefferson Health and alumni professor and chair of family and community medicine at Sidney Kimmel College of Medicine at Thomas Jefferson University. In these roles, Dr. Flattau leads one of the nation's most prominent academic family medicine departments while overseeing population-based primary care for more than 1 million patients across Pennsylvania and southern New Jersey. Her scope of leadership spans traditional and interprofessional primary care, telehealth services, integrated behavioral health, medical weight management, complex care models, and community-based care, reflecting a comprehensive vision of primary care as a foundation of health equity. Prior to joining Jefferson, Dr. Flattau served as the Vice Chair for Clinical Services and Director, Strategic Development in the Department of Family and Social Medicine at Montefiore Medical Center. There she led the growth and management of clinical services serving Bronx communities, including primary care, inpatient medicine, women's health, palliative care, and wound healing, while also strengthening training environments for future physicians. During COVID-19 pandemic, Dr. Flattau founded and directed the Family Resilience Fund, a regional collaborative that provided direct cash assistance and social work support to more than 1,000 children whose caregivers died of COVID-19. A powerful example of how healthcare leadership can extend beyond clinical walls to meet urgent community needs. Across every role, Dr. Flattau brings a rare ability to link vision, systems design, and implementation, ensuring that care models are not only innovative, but humane, equitable, and sustainable. So I just want to take a moment to welcome you to the podcast.
Thank you so much for having me. I appreciate it.
Now, I appreciate you and the work that you do. So I kind of just wanted to start off to begin. What first drew you to family and community medicine, and how did your early experiences shape your commitment to primary care as a driver of equity?
Yeah, I think when I first started thinking about medicine, I was really drawn to the idea that I could have a skill set that was of use to other people, that other people wanted, that was sort of portable with me, right? Because it's a skill you bring with you. But that also let me sort of travel, and maybe not literally across countries, but travel to different types of people, right? And different types of communities, and really hear from people, talk to them, understand what's going on in their lives. Because that just struck me even when I was very young as something that was just perennially interesting. And so it wasn't really until I was in college that I started thinking about medical school, but during the course of college, I decided to go in that direction because it seemed to marry both a professional trajectory and a way of developing my own skill sets and being useful to society with just curiosity, right? And the kind of the ability to pursue the joy of just learning the different things from different people. And I think that was a good move on the part of my younger self, because even when I see people who are late in their career, that's actually what they always say. What they still enjoy is the interpersonal relationships. They value their patients, they value their colleagues, they enjoy interfacing with different communities, their own and that of other people, because that joy never goes away. And so I've really appreciated the many paths within healthcare and within medicine. It seems like a narrowing in some ways when you say, okay, I'm going to go to medical school, but it actually opens up like 1,000 pathways that you can then choose from over the course of your career to do different types of things based on what you discover about yourself and what you discover being possible in terms of work and places and ways of working.
I love that. And I think your younger self would have never known or thought that you would be to where you are now, and leading over, 1 million patients within the area, which is huge.
It's a lot of people, yeah.
Yeah, it
It's
is.
like it's a small country, is what I always say. So we actually looked once at the list of World Health Organization countries, and there are 40 countries that are smaller than 1 million people. And so we would joke about like they're the 41st country, right? When you look at different sizes. So it is a lot of folks.
No, but it's beautiful that the work that you're doing. And also too, I wanted to kind of ask, you lead at both the academic and enterprise levels. So how do you navigate those dual responsibilities while keeping patients and communities at the center of decision making?
Yeah, I mean, people ask all the time, how do you divide your time between the health system role and the medical school role? And it's not really divided; it's really merged. And Jefferson has a model where, for most clinical areas, the academic chair and the health system leader is the same person, and that's intentional because both sides really enrich each other. So some of that is very literal, right? We train people in clinical environments, right? So some of medical school or nursing school or PA school. Some of that is didactic, and you're in classrooms or listening to lectures or reading. But a lot of it is experiential, right? You're being trained in the clinical environment. So quite literally, the health system is where we do education and training for health professions. Same thing for research, right? There's some research that's done in a lab, but a lot of research, including really all the research in my department, in my field, is embedded in the health system, right? We're looking to understand how patients move through healthcare and what their health conditions are like, and how we can best help them. Or we're implementing different programs and kind of testing what works for folks, right? And what is worth continuing over time. What's the best way of taking care of people? So it's literally very integrated. I also think the two different work cultures sort of play off each other in a really useful way. Health systems are very like operations oriented, right? So we want to improve quality within the next 12 months by this amount and come, hell or high water, we're going to do it. And like we go through like a very clear process of how we're going to achieve that, for example. So it's I'm tempted to use the word corporate, but that's often used in a pejorative way. I think there's actually useful things from that culture, though, that measurably improve human health and measurably improve patient experience for real human beings. And that is a very healthy world to be in. It also forces you to think rigorously about how we provide care in a way we can sustain, because if you can't sustain it, you can't provide it, right? Those programs don't survive. And we want to build wonderful patient-centered programs that we can grow and serve everybody and that we can sustain over time. So the health system teaches us about how to be real, right? How to be real in hitting metrics and how to be real in providing care that attracts patients to choose Jefferson, because we want people to come through our gateway and allow us to serve them. And it helps us to think creatively about, okay, what's the right care model that's sustainable, right? Or how can we manage the very complex financing mechanisms under healthcare to make sure that we are reimbursed so that we can continue to do this work as a nonprofit organization. The academic environment brings a whole other set of skills, right? So it's the skills of like inquiry and creativity, and it's the skills of questioning, right? And doing things that no one's done before, and testing and taking, risks in terms of intellectual risks, right? Of how we're going to try and do things in different ways. The academic side also has a much more sophisticated view to measurement, right? It's not just let's compare what happened here and what happened there. We're looking at like the statistical models and how the comparison was done and what those groups look like. That rigor really is great for how we develop our programs, right? It's a different level of rigor of thinking and rigor of inquiry. Because in academia, if you're going to say something, you have to go through a peer review when you submit that publication or when you submit a presentation, and experts in the field have to agree that it was a well-constructed argument. So it teaches you that. Also in academia, the way people have careers is very different. People are often in one place for a very long time throughout their professional career. Sometimes they change jobs, but the cultures tend to be of really thinking with people about long-term careers. And some of that we do in the health system as well, but I think I do that better because of my work as a chair, where I literally, as part of my contract, meet with all 70 or so of my faculty members in that academic department every year to talk about their long-term career trajectory. Where are you now? What about 5 years? What about 10 years? What are your lifetime career goals? And it helps you to think about people in a different way and support people in a different way. And also just kind of open up broader fields of all the many things that people can do with their ideas and their skill sets and their own creativity. So I think that the kind of crossing back and forth is like a marriage, right? Like people cross back and forth their different characteristics and skills and things they like to do. I think it strengthens the whole thing. So we are an academic health system. I think I always say we're an academic primary care system, and I think that ends up actually being better for everybody. We're excellent at it every day. We can do novel things. We can do things at scale. We can do hard things. We can train new people. We can think in different ways.
No, I love that, especially when you said that they're not separate, it's merged together. Um, and you're working, in the healthcare system, but also in academia and being able to keep the two together and they're not separate. And I think that's a beautiful model that Jefferson has. And also, too, when you think about health equity, what does that look like in practice, not just in outcomes, but in how systems are designed?
Yeah, so health equity is critical for us to provide good care, right? If you're not providing equitable care, you're not providing good care, right? Um, Now, in a world that doesn't exist, right, you would just do everything the same for everybody and you'd have equitable care. I think it's important to recognize the forces that push towards inequity. And I think I like to think about it that way because inequity is not a natural state of affairs. It is our current state of affairs, but it is not a natural state of affairs. It is an unnatural state of affairs because of underlying forces that drive you towards inequity. And because of that, we have to be attentive to those forces and drive back towards equity, right? And not say, well, we're just going to be the same for everyone, because that fails to recognize that we don't live in that paradise, right? We live in a very different world. And it's not a side project, right? It's in everything you do. You have to be cognizant in everything you do, in every system you build, in every quality improvement project. You have to be cognizant of the fact that that wind is pushing you off course, and you have to realize there's that wind and make sure that you're holding your course to helping all people in the right way that's right for each of them. Now, some of that is in allocation of resources, right? And making sure that we are providing the same care to everyone, including the same level of respect and listening. Some of that is being humble enough to realize your own assumptions may not be everyone's assumptions. Your own values may not be everyone's values. And your own way of coming to a conclusion and making a decision may not be based on the same type of things
Mm.
as somebody else, right? So you can be telling someone about the evidence over and over again. They may be coming at it at a completely different epistemology, like a completely different way of knowing. And that's equally valid, right? But different. So you have to, kind of understand that. And there's, you know, aspects of social needs, right? So if you're not looking to understand what's truly possible for folks, you can't help them, right? So you have to, do everything we can to address that piece as well. Um, and then, thinking about ways that we perpetuate prejudice, right, or perpetuate inequities in the way we interact with people is very real, right? The evidence is there. If you don't believe in evidence-based medicine, you can't be a physician, right? So if you're a physician, you have to believe in the evidence base, and you can't say it's not true because all of our decisions are based on evidence, and that evidence is there as well, right? So taking that into account, recognizing that people's experiences are real and they're often negative in healthcare, there's that wind, right, that you have to work back in the other direction about. All of those things are important. I also think, and this is far from a novel statement, but the way we look and who we are says about how we integrate with our communities. And it is also not natural that if a healthcare workforce does not look like the communities we serve, it's the reality, right, in most places, but it's not natural. So then again, that link to academia, right, and how we think about ameliorating that unnatural situation that we live in and not pretending it's natural, recognizing it's not natural, and that we have to address those underlying forces is very important. And having the ability to train people, of course, gives some tools to help with that piece as well. And that's true for all communities, right? It's true for communities of color. It's true for our rural communities, in Eastern Pennsylvania. Broadly true, right? So there's not a day where that doesn't come up or a project where that's not important.
I agree. And especially when you touch on how important it is, like tying in academia into it all as well. And also, too, like as your role as Enterprise Chief of Primary Care, what principles guide your approach to large-scale system leadership?
So we are a very large system, right? And we, like many healthcare systems, are the product of mergers between many other health systems that all came together and came to be one. And I've been here about 4 years, so I came right as many of those mergers had happened, and we then merged right after I came with Einstein, Philadelphia, and Einstein Montgomery, and now Lehigh Valley, which is a large health system, also came into the fold. I think for our journey, in our primary care system, the secret sauce has really been sort of a participatory governance model of leaders from all of those different areas of the organization. And I always say that the best thing we ever did in the beginning was set up a governance group where all of those leaders are represented. Because it is true that you come to better decisions when you have a diverse group around the table. And that group has a lot of diversity in terms of organizational background, experience, the communities they serve, who they are personally. Some are academic, some are community-based, all sorts of different backgrounds. And so if we all agree on something, it's probably true, right? Is what I say. Like, it's probably a pretty good decision, right? If we're all agreeing on it. And we do come to agreement pretty quickly on actually almost everything. It also allows us to balance the need to make centralized decisions and execute on them and bring, everyone along, right? I think like a flock of birds, right? Everyone's like fly in the same direction. But we also want to listen to the reality of what patients need and what those interactions are like for our clinical teams. So that structure allows the regional leaders in all the regions who really know their practices and know the clinical teams and the physicians and the other clinical team members to really hear from them, bring that back into the middle. But also when we're in that middle together, and we're talking about some of the complexities or subtleties of why a decision was made, right? Or why we need to execute an initiative, they can then speak to that directly to the folks that they're interacting with. And we really leverage the regional leaders because they know the practices, right? And they understand what's going on in reality. One of the things that's sort of particular about healthcare is the people with the greatest expertise are the ones who are actually on the ground seeing patients, right? They're very highly trained. And even folks who may have fewer years of professional training, like medical assistants, they're seeing patients all day. They have a very high level of expertise in what's going on out there. And whereas some kind of classic companies, like the further down you are, quote unquote, from the centralized leadership, maybe the less skills you have or the less knowledge you have, is actually flipped in healthcare, right? Where the person seeing the patients is the person with the most knowledge. And so you have to be extremely respectful and have your ear to the ground to hear what those people are telling you because they know better, right? And that structure that we've created, which is an inclusive kind of pluralistic governance structure, allows us to hear people and also to be able to move as one organization forward.
I love that, especially when you touched on that governance board, because most people don't know how organizations are structured, especially large healthcare systems. So I really appreciated that part. And also, too, to tie into that, how do you balance innovation with sustainability when designing care models for diverse populations?
So, with great care. And so, healthcare is very complicated, and some of it is that, like the healthcare part of actually treating the patients is very complicated, right? Treating patients, families, and communities. Also, our system is just complicated in the United States. Maybe it's complicated in every country. Certainly, it is here. And it requires really deeply understanding the finances of healthcare, which are not straightforward, to be able to understand how services are sustained and strategically position the way we structure our care teams in a recoup the dollars that we deserve, right? That we're supposed to recoup for services so that they are sustainable. I worked most of my career in FQHC, so I've worked in a lot of communities that are low income. It's very hard to provide good health care if you're labeled as a loss leader or being told you're being treated like a charity case, right? That's not where anyone wants to receive care, right? No one wants to go to receive care in an environment that's a charity case. So I've worked very hard at understanding the mechanisms of healthcare finance at the health system level to build things in ways that demonstrate the value, not just the human value, which is important, but also the financial value or the business modeling value, so that it's scalable and sustainable. Because it's very hard to set up a new program. It takes 2-3 years easily. So you want to invest your efforts in ways that are going to be sustainable. And it requires, sometimes some creative thinking about the modeling, right? What's our care team model? How are we going to engage patients? What's the package of services that we can provide that's high value, in order to get to that place. But I would say that we've been really successful at doing that, right? And primary care is an area where many people will say, oh, it's not a revenue generating area. It's actually not true. When you really look and understand all the different ways that primary care contributes, we do not need to apologize to anybody, right? We deliver a lot of value. And that is a very important thing because it is our ability to say we deliver financial value that gives us safety and being able to provide the services that our patients need. So it's really not, I don't see it as two different things, right? The drive towards improving finances and the drive towards taking care of patients. Having worked in a lot of low resource settings, it's the same thing. No one wants to go to a low resource healthcare setting. They want to go to a good healthcare setting where they're getting what they need. And so we have to build that for everybody and make sure it is given to everybody. Now, it's interesting, in community-based primary care, right? Because um, we live in a very segregated society and we have very segregated geography. So when you're in a community-based primary care site, you're often seeing poorer people or wealthier people or middle-class people. Sometimes it's mixed. But when you look at the system, it's everybody. And so I actually think it's helpful to have an everybody system because everybody is getting that standard of care and everybody deserves the same standard of care. And by mixing people together in your view, you're making sure that everyone is achieving the same outcomes, right? Because you have the same standard of the same outcomes for everybody, regardless of which sites they're in. How you get there might be a little different, but your standards are going to be the same. In our large university practice, we actually have a huge range of patients from like every socioeconomic group that you could possibly think of, racially diverse. And it's interesting because it's the first time I've been working in a site when I came here 4 years ago that's not a community-based site, but it truly is like all of society is in that waiting room together. And I kind of like that. It's such a great visual of like how we're literally doing exactly the same care, literally for everybody in the same place in the same way. And we want to achieve that on a system level as well, providing that in the communities where people live, but with that same commitment to having the same, like all our patients have the same standards for what they want, right? They want really good care, and we need to deliver that across all of those different settings as well.
I love that, especially when you touched on how important primary care is and do not need to apologize for how important it is for the community.
Yep.
And also, too, I wanted to touch on integrated behavioral health and complex care are central to your work. Why are these models critical to improving outcomes and reducing disparities?
Mhm. So the vast majority of mental health care and behavioral health care is done in primary care. It's just a fact, right? The psychiatrist will be the first to say it, right? There will never be psychiatrists for the 100% of human beings, right, who have some sort of, grief, pain, depression, with all the things that we all go through, some more than others in life. So most behavioral health care is in primary care, which means we need to do it well, right? And we can't, no one's going to come riding in and, decide they're going to help us with all of those patients. Like we actually have to learn that as part of our core skill set. I think primary care physicians in general have known that for a long time. And so we've worked really hard at training ourselves in how to do behavioral health care for most people, right? People who have complex behavioral health needs do need a specialist and they need to go to a psychiatrist. But we can manage depression, anxiety, a lot of, the common things that we see that really can make people suffer and that are very treatable. We've also invested, though, in building systems, right, in order for that to work well. Because many things, right, the physician or the nurse practitioner or the PA we can't do it on our own. We need a system. So we've developed at Jefferson, and many health systems have done exactly the same thing. We've developed an integrated behavioral health system, and what that means is it's therapists, right, who are part of our primary care team. And if I have a patient who needs therapy, and that might be that they have clinical depression, it might just be that like they lost someone they loved, right, or their boss is like really toxic, right? Or just something that was hard being a person, right? It's like so sometimes you just need that backup. I can just refer to the behavioral health consultant who is part of my clinical team, and they will in person or via video provide counseling and therapy for that person and additional diagnosis and treatment. And that is critical, right? Without that, we couldn't provide evidence-based care for behavioral health. And this lets us provide like a high quality and consistent quality of care for all of our patients. There's a lot of additional things we've built onto that. So we have a model with remote psychiatry oversight of how we're doing medications to support primary care prescribing of behavioral health, and psychiatric medications. We created a substance use treatment aspect to this. So some primary care doctors are comfortable prescribing Suboxone, for example, for opioid use disorder. Some are not, or just, they're not doing it frequently enough to be comfortable, or may not have the staff to help coordinate and follow up with the patients. So we've built a system where we have several addiction medicine certified primary care doctors who, if I don't prescribe it because I'm not comfortable because it's not part of my skill set, my patient remains my patient, but I'll have them do a telehealth visit, right, with the person who's able to, with high levels of expertise, assist them with treatment of their addiction, and they can get that all taken care of in primary care, even if their particular primary care doctor doesn't have it as part of their skill set. That was a very important add-on because it's hard to get access to treatment, and this is a very discreet, easy, accessible, supportive, and high quality way of providing that service.
No, I love that, especially as we're talking about access to treatment and to care, tying that into, especially as now with technology advancing, what role does telehealth play in expanding access without compromising relationship-based care?
Yeah, so I've become a big fan of, virtual services. I've been around a while, so it wasn't like totally natural to me at first. But people love it. So that says a lot, right? We have for a long time, and especially since COVID, right? Everyone has created telehealth capabilities. And for even like someone who has a traditional practice like me, like in my visits during my clinical session, there might be one or two that are telehealth because the patient can choose which, whether they want to come in or whether they want to have a telehealth visit. But we've actually developed a lot of telehealth only or telehealth predominant services. So the behavioral health consultants, the therapists I was just describing, the vast majority of what they do is telehealth because patients just don't want to come in over and over again, right? It's just very convenient. So that's by far the preferred method for patients, which is their choice. It's the choice of most people. Their services, for example, we've built out a very large and growing medical weight management service, which manages GLP-1s or other types of approaches to weight loss and does nutritional counseling, like a really nice comprehensive wraparound service. We thought a minority of people would want to come in person. It turns out almost zero people want to come in person. And they don't have to, right? There's no need for them to do so. So that has become almost entirely a telehealth service. We offer in person. People are happy doing the telehealth. It's convenient. Their needs are met. And then about a year and a half ago, we started a virtual primary care service. Unlike coming to see someone like me, where I'm in person, you can choose a visit to be virtual if you want. This is only virtual. So those physicians and nurse practitioners in that program only see you virtually. They don't have physical practices. And it was interesting because I think we had a lot of hypotheses about like who would want this, was it going to grow? It turns out this is incredibly popular. And so every time someone calls Jefferson or goes on our website to make a new primary care appointment now, they're offered traditional or virtual. We have about 500 people a month currently signing up for virtual primary care, and that's only going to grow as we find other ways of presenting it to people as an option. And it turns out, we thought, well, we're going to do this. And, when people need to come in person, they can come to any of our practices and we'll arrange that and make sure that they are given an in-person visit on the times when they need it. That's still true, right? And if they're seen virtually and they need to come in, we will get on the phone, call whatever practice is near them. They will get a visit, no problem. It's vanishingly rare that actually that's needed. It's very interesting because I thought that was going to happen all the time. That's the way I was trained. Almost never. Turns out that we can send people testing supplies. We can send them blood pressure cuffs. Some people don't need a physical exam because it's frankly not always necessary. Those who do can come to urgent care at one of our practices. Sometimes they've just seen a specialist, so they sort of just had an exam. And we have the capability of seeing them, but it turns out it's pretty rare. And we've been the team has been very creative about finding ways to get people the supplies and testing that they need, the weights and blood pressures and so on, to really do a great job in managing their care. We all, I think there was a hypothesis that, okay, who's going to want this? It's going to be all these like young techie people. It's actually everybody. And we started to look at the population of folks who voted with their feet and signed up for this. We did an analysis of we did geocoding, which means you take people's place of residence and you can figure out just publicly available characteristics of the neighborhood where they live. So we looked at socioeconomic status based on just people's home addresses. It's like a solid stripe from the richest to the poorest, like everybody like is sort of evenly signing up for this, which is very interesting. Um, in terms of age, everyone was like, oh, it'll be all these young people. And there's a huge surge in like what I think of as like the child rearing ages, like the people in their 30s and 40s, but we have a 102-year-old patient. There's a lot of older people who are signing up for this who like it, right? Everyone was like, oh, there'll be all these healthy people for virtual. No, like there are a lot of really like complex people, and we're getting droves and droves of people who have hypertension, diabetes, uncontrolled, and they weren't able to get into the visit because it takes half a day and you have to get there and you have to take time off from work. And a lot of people don't get paid when they take time off from work, or they get dinged, or their kids are, they're taking care of their kids. They can't get in here. And so it's great, right? And they're able to, 20 minutes, they dial in from wherever they are. We see a lot of workplaces in the background of, the telehealth, and take care of their needs and move on. And in retrospect, it doesn't surprise me because just the patients I have who choose to do telehealth and are often like working people who have significant chronic, illnesses, but they just can't get out from work, and they don't need to, right? We can really work around people's lives and help them. So that's been very exciting. And we're starting to work with our community outreach team. When they go to a health fair and they tell someone they have high blood pressure, well, then what, right? If you can't get an appointment for 3 months, like that's not super helpful. Now they can actually use a QR code and just make an appointment right away. And we're able to maintain access really good at like quick access because we don't need new buildings, so we can hire people and keep and keep building more access, which is like a very freeing thing for us to be able to grow so fast. The physicians love it too. We've hired fabulous physicians and advanced practice clinicians because it's very patient centered, and they can work from home, but very experienced, dedicated people. The difference between this and the also useful services that like an urgent care might give or that Amazon can give you is it's still real primary care. So you get your person, they're your personal doctor. They will, until you fire them, right? They will continue to work as your personal doctor, and be really comprehensive, talk to you about all of your health needs, not just take care of the thing you need done that day, but really think with you about your whole health picture and all the things that we can do to help you, including behavioral health and including a whole new lifestyle program we just rolled out so people can get a year's worth of coaching around healthy lifestyle, all the stuff. So we're very excited about that program because it seems like a great way of opening virtual doors to thousands of people who might not otherwise be able to easily engage in healthcare, and giving them a really high quality service that also connects them with any other resources they need in our health system.
No, I love that. And I think that um, telehealth, like you said, it opens up doors because there's many people that can't take off from work, or,
Yeah.
they have to pick up the kids at a certain time. So all these daily responsibilities, you start neglecting yourself.
Yep.
So be able to
Yeah.
still, yeah.
I don't go to the doctor like that much, right? So because like I said, like a lot of our employees, the people who designed the program, signed up for the program. That's when you've hit a nerve.
No, because you're just working so much and it's hard
Right,
to
it's
keep up
hard.
with yourself.
Yeah.
Um, so also too, like I wanted to touch on the Family Resilience Fund. It was a powerful response to a devastating moment in our healthcare history. So what did that experience teach you about the role of health systems in a time of crisis?
Yeah, so that was truly a response to need. I was in the Bronx, during the COVID pandemic, and it was bad everywhere. It was really bad in the Bronx. We were the epicenter. We were the first to get hit, and it was the most severe, really in the country. So it was a mass death event. I mean, it was a catastrophic humanitarian disaster. by any description. And it really started with our physicians, our care teams in the hospitals that were so distressed because people were just dying. Lots of people were dying. Like, they were just dying and dying. And many of them were parents, or caregivers, right? Maybe it was the grandma who was taking care of raising a child. Often it was parents and fairly young people. And, the Bronx is a kind of middle income, low income, group. So these aren't like even someone who's relatively well off, if you suddenly out of the blue lose a caregiver or a breadwinner, what do you do, right? I mean, it was very, very tragic at huge scale. And everyone was in shock, right? And also every system had failed in our society except for healthcare. We were the last ones standing. And like we were all people had, like there was nothing else open and there was nothing else functioning well. And then what, right? Like so what we realized was, well, maybe we can at least help people just keep their head above water for a month, so that they can figure out what to do. Often, sometimes it was the sole breadwinner, one of two breadwinners, and like they had no food the next day. Like there was no ability to feed their children. And sometimes it was the caregiver, but if say you have a mom who's at home as a full-time mother, like if she dies, the other person can't go to work, right? Because they have to stay home with their children. So it was a financial emergency for a lot of people who really didn't have cash reserves. And even those who had some cash reserves needed a social worker. Often they were people who never thought they would need a social worker because they were middle class, but all of a sudden they did because they couldn't meet their rent payments, all of a sudden, or their mortgage payments. So we just decided to do the best we could do. We were fortunate to find philanthropic support from the Robin Hood Foundation, which is a philanthropic foundation that's based in New York. And it actually grew much bigger than we thought. We originally asked for $50,000, and that we ended up going through well over $1 million in cash assistance and some support for our social workers. It was a combination of referrals, right? So we literally just like called everyone we knew at all the regional hospitals and community-based organizations and health systems and said, if you know people where there's a child in the home, because that was the most heartbreaking of all, send it in, right? We built a system for this, right? Privacy respecting system to send in referrals. And we were able to give them $2,000 in cash and a consultation with a social worker just to keep afloat for a little bit. And then we also went through a very sad process of pulling out all the deaths in the hospital from our electronic medical record and going manually through the charts because there's not like a clear way of pulling like did the person have a child, were they a caregiver? So our social workers, like it was very traumatic for them, honestly. They like went through hundreds, thousands, like of these charts and like identified people who had left children behind and called and reached out to the surviving person and said, hey, we're here to help you. And it was a coalition regionally, right? It was something we couldn't sleep, so we did this, right? After working all day, but it was really meaningful. And I'll always remember that um, a lot of times like what was so meaningful to people, like they did need the money and they needed the help navigating with a social worker, especially when everything had shut down. They were also just people would just cry that someone had reached out, right? They were so isolated and this was so sudden, and then there was nothing to help them. Just the fact that like we remembered them was really important, particularly because they weren't there and their family member died, right? So they didn't really know if we cared, right? In some level. So like they knew we cared because we bothered to reach out to them afterward and made it like a real effort to try and care for them and their child. I think it also gave them confidence that we'd care for their family member who passed.
No, I agree. And I think that a lot of people too during that time, it was tough. And the fact that you created a whole program and specifically on if is there a child in that home and reaching out to that surviving, family member is really important to even if it's just to someone to just talk to. I know that those families really appreciate that because sometimes you just need to talk
Yeah.
and vent.
Yeah.
But also that cash assistance part is really critical because folks did lose their jobs.
Yeah.
And there was not jobs to apply to. So
Yeah. It was I think it's also just a lesson that like we can do hard things and we can do new things, right? Because health systems don't usually do that, right? We don't like do big cash assistance program. So, but we saw a need and we figured it out, and there was a lot of like mechanisms under that were not things we knew how to do, and we just figured it out. How to do the distribution, right? How to like all of it. And so I think it just shows like our ability to be creative on an institutional level when motivated by a clear-eyed view of the needs of our communities.
I agree. And also, too, what advice would you offer women, particularly those navigating academic medicine and executive leadership, who want to lead without losing their values?
Yeah, so the way I always think about this, people tell you things all the time about what you can and can't do, and they message that in all sorts of ways. And I think for women, it can beat you down a little bit, right? And I think the truth is we all feel that. It's probably true for everybody, right? For men too, but particularly for women. And it's hard not to internalize that sometimes, right? Because it's like it wears on you over time. So I think taking what people say with a grain of salt is important. And I always think of it as like you want to hear what people have to say because sometimes feedback is important, right? None of us are perfect, but in terms of like where you want to go and what your vision is for yourself and who you know you are, that you want to hold on to while listening on sort of a lower, more micro level to some of that feedback. Because it's real, right? Like people will define you, and if you start believing that, it will limit your capacity to grow. And sometimes you need to see yourself in a place where the people around you maybe can't or choose not to and persist in that. It doesn't mean you're flawless, right? Like you have to accept we're all flawed. Everybody is flawed, right? No matter who they are and what they're doing. And so you want to be humble and get feedback, but not let that define you, right? You get to define how you want to move forward and not be made smaller by other people.
I love that. And then also, as you said, too, taking what people say with a grain of salt.
Yeah.
That's really important as you're coming up through your leadership journey. And also, too, when you reflect on your career, what legacy do you hope to leave in primary care and population health?
I hope so. I always say like someone who's done a really good job can walk away and it all keeps working, right? So I think there's two pieces of that. One is like I really like building systems, and I like it because they keep going, right? Like they thrive. It's like a perpetual motion machine, and they a well-functioning system, or whether it's just improving processes or building out new wings of services, create further opportunity, right? Because you have that infrastructure, you can then do whatever is next, or someone else can come along and do whatever is next to further serve. And then the other piece is really cultivating other people, and that's probably the most rewarding thing in anyone's career is helping position, structure, coach, help people to kind of spread their wings and fly. And some of that is teaching, right? And some of it is just getting them in the right room, right? Because a lot of how you learn things is socialization, right? So if people aren't exposed to the right environments, they can't, learn. And some of it is helping them see their own trajectory and kind of aiming high. Because most of the time people have more potential than they realize in the majority of cases. So like that's the legacy, right? As you build systems that persist and people who will continue to grow those systems and others.
I love that. And also, too, if you could change one thing about how healthcare systems invest in primary care, what would it be?
Um, hmm. I have to pick one, and that's a really hard question. So I think, for me, the key issue with primary care, because the way we generate value is complicated, right? It's in multiple different financial levers. We spent a lot of time advocating to get all those levers put in one business plan, like literally in one spreadsheet, so that we could talk openly about where we do and don't bring value and where the costs come from. So for me, it's about accuracy, right? Let's accurately assess the value, not be lazy and use like a spreadsheet that's meant for a different type of service or that was used a long time ago, but accurately, again, clear-eyed, right? Look at how that value is produced so that we can make informed operational decisions based on financial reality, not asking for financial lack of reality, right? Some things just aren't going to happen, right? And can't be sustained. But let's take the time to understand that complexity of healthcare so we can be strategic in our investments. And in primary care, that generally works for you, right? When you really look and set aside the assumptions and really look at the hard, cold numbers and let that change your operational reality, it does work in the favor of primary care because we are the kind of front runner, right, of health, family health, community health, public health, and both improve the quality of people's lives and also do so in a cost-efficient way by working on prevention and earlier disease management.
I agree. And then also too, I kind of wanted to piggyback off of that. What message do you want future physicians and healthcare leaders to carry forward from your journey?
I think to be curious and also insist on others being curious and be open-minded in thinking about how to produce high-quality healthcare. I think, physicians and clinicians, like we're already motivated to provide excellent clinical care. There's a lot of clear structure to help us to do that. It's being able to maintain that the observations of how things could be different or what people need, which honestly another advantage of academic medicine is you have young people come along all the time being like, why are we doing this, right? So like having that ability to look with fresh eyes while also bringing expertise, for me that's the key balance of a physician leader or any clinical leader.
I love that. And especially when you said balance, how that's really important too. And also too, how can listeners stay connected with your work and the future of primary care at Jefferson Health?
I'm a fan of LinkedIn, right? That's my platform. Our health system also does a lot of, um, public relations and like tries to kind of get the word out on some of the things we're doing. Always, welcome these types of opportunities because I think healthcare is a social good for our communities and it is important to understand what we're doing. Hopefully what we're doing is really of benefit for people and engaging for them also, society is something that we all produce together, and the way that patients and communities and individuals like advocate or shape the discourse, or protest or change, like that really does impact how our societies move over time. So those pieces are really critical as well. So we're always looking for opportunities to engage in discussion, and this is a great opportunity to do that as well.
I love that. So everyone, please connect with her on LinkedIn. That's one of my favorite apps too. I love LinkedIn. I started using that when I was 18 and it really has helped my career. So please connect with her because she's doing amazing work within the community. And I just wanted to say, Dr. Flattau, thank you so much for your visionary leadership, your commitment to community-centered care, and your unwavering belief in primary care as a foundation of health equity. Your work reminds us that strong systems are built not only on strategy, but on compassion, trust, and accountability. And to our listeners, if today's conversation resonated with you, visit angelsprotection.org to learn more about our work supporting women, mothers, and future health leaders through education, advocacy, and community care. And always remember, science protects systems, not people. So let's keep breaking it together. And please like, comment, and subscribe. Take care, everyone.